So I'm really pleased to be not only at the AATS Mitral Conclave 2015, but to be joined by Dr. Tirone David. Tyrone's obviously well known to all of you. Tyrone, you were president of this organization in 2005.
10 years ago.
That's incredible. When we were all young.
That's right.
But and I heard you talk this morning. I mean, it looked like 1,200 people in there. It's phenomenal
amazing.
Meeting.
The interest is amazing.
It's phenomenal. So let me ask you. I've got three simple questions for you. You're an incredibly accomplished mitral and aortic valve surgeon. Is that possible in the future?
Well, everything is possible, but it's much more difficult now than I guess it was for me. The technology in 30 years exploded.
Correct.
None was available 30 years ago. Very basic principles of valve replacement, valve surgery. And if you take a look what happened, I mean, for anyone starting today to acquire this amount of knowledge, to become skillful in both,
I mean,
it'd be very difficult.
I mean, people, obviously a lot of surgeons do mitral, but you're incredibly skillful in both.
But I lived the transformation of the field. I was part of it. I introduced several new techniques for both. But that was a learned experience from step by step. One of the lectures I gave several times was on surgical creativity. How come some people can come up with new ideas, others do not? If you take a look at every creative surgeon, is a very knowledgeable surgeon. They have lived all the basics. They know the basic in depth to be able to move to a higher level.
That's interesting. I'll come back to that. Do you think that we ought to, moving forward, have super specialization of surgeons? Should we have mitral surgeons, aortic surgeons?
I think we have to do that, to be quite honest, because to become an expert, you need a minimum volume. You have to operate often. The average American surgeon is doing 5 mitral valve operations a year. How can you become an expert if you see something or do something 5 times a year? How can you be an expert in interviewing if you do 5 times a year? No,
you're exactly right.
I mean, if you take a look in why experts become experts, it's a 10,000 hours rule. It's
practice. But even then, I mean, to become really accomplished, and you know, obviously you're very creative, you were very talented, you were in one place, correct? I mean, for most of your career, you were in one place.
Hospital, yeah.
Correct.
Single hospital, same patients.
But in moving forward, I mean, guys or gals who are surgeons will become in mitral space, and the same thing in aortic. Is that right? You think?
Likely I think so. I think, and that's the way things are settling down. Larger collaborative group practice between cardiologists and surgeons, and have a surgeon, an expert in one area of heart surgery.
I don't think there's any doubt. I mean, I think, and it makes sense because then they become proficient in that space. So tremendous changes. Well, there's always change in life, but tremendous changes in the last
about life is going to change.
5 to 7 years. I mean, the TAVR thing. When you think back 20 years ago, and you think about that. So how do you picture valve surgery or valve intervention in the future? Where do you think we're going to be?
I don't think it's going to disappear in our lifetime. It's going to be better techniques. What we need at the present time badly is a patch material. A patch material can replace part of a valve and is able to heal itself just like our own valves do. And we don't have that yet. If we can find a substitute for the leaflets, for the cusps, that is able to repair itself during the cardiac cycle, then we're going to solve the problem of heart valve disease.
Interesting.
Meantime, it's all palliation.
I understand that. And you think, what about, do you think that the surgeon or surgery of the future is going to be catheter-based more than surgical approach, or we don't know?
I think we do know. I think the surgical pathology is going to remain largely surgical domain.
Okay.
The catheter base is going to be highly palliative and remain palliative for the nature of the problem. Yes, if you offer a patient a solution 2 hours in the cath lab and back home tomorrow. They all take the 2 hours
Absolutely.
back home tomorrow. But if they know the implication 5, 10, 20 years later, and they are serious about their health, they'll take the other option. Remember, mitral valve repair and aortic valve repair, they have provided outstanding long-term results.
Absolutely.
We have now 25 years experience in aortic valve repair. They are better than mitral valve repair. So you clip or something in aortic valve provide 20 years, pretty much event-free survival. I doubt it very much.
Tirone, is the mitral space different than the aortic space? In other words, people. I mean, the reason I'm thinking about this is both the complexity of surgical approach and complexity of transcatheter approach. I mean, you've lived in both space. You've developed
Mitral
techniques.
valve is much more complex physiologically because not only a valve, but it's part of the ventricle.
Correct.
A part of it is attached in flow. Part of it is supported by the ventricular muscle. This alone makes a function very complicated.
I mean,
The aortic is simpler.
I didn't want you to think I'm stupid asking that question, but I'm thinking about
sure.
about therapies.
So it's much simpler to intervene percutaneous in aortic and pulmonary than would be in tricuspid and mitral because atrioventricular valves are more complex,
That's going to influence
structurally and functionally.
That's going to influence our
Developments.
approach and our development.
Absolutely.
So are you very optimistic about the role of the surgeon in the future in valves?
I remain very optimistic. I think if anything, we should, if you take a look at the major changes in therapy, it's always surgical.
It's always surgical.
I mean,
No. I mean, the reason I'm asking that, some people have said, "Gee, I think surgeon's going to be a hybrid. It's going to be a catheter-based thing."
I doubt very much if a single human being possesses the skills to do techniques to the catheter as well as open and tri-dimensional visualization by eyesight or whatever, cameras. I think the set of skills are different. You might find an outstanding surgeon to operate in open procedures, but I doubt very much they had the same degree of dexterity on catheter basis.
Interesting.
Catheter-based guys probably, our brains require different sets. Of course, some guys are going to be outstanding in everything, but they're the rare breed.
So going back to the final question about your creativity sort of thing. I mean, what's the basis of creativity?
Well,
Is it genetics?
No, I don't think it's genetic. I'm not very intelligent. My intelligence is the average. So it's not being a genius, not an Einstein. Sure, those guys are lucky. Most of us who are creative, we are very knowledgeable and curious. It's the Thomas Edison.
And
99% perspiration and 1% inspiration. That's
so really being experienced
keep working at it.
and keep pushing ahead.
Trying to find a better solution for the present problems.
Well, you've given us better solution for a lot of problems. I mean, you've made tremendous contributions in
I
your
don't know if you
career.
heard my talk this morning.
I did. I heard you talk this
Simple about
morning.
incisions and not to expose a heart. But the most important thing is to record what you have done and follow to make sure what you did worked.
No, I think
If you don't look back, I mean, how do you know it works?
No, everybody's interested in the size of the incision, and it's really
Which is
the
a
outcome.
mistake.
It's the durability. Where you, as I said, you've made tremendous contributions. You've been a shining light in this field. Thank you very much.
Thank you.
Okay.